my pleasure to welcome Professor Neil Shear from Toronto to lecture here today, and I'll call upon Professor Bergman, Professor Uwe Bergman, to introduce our distinguished lecturer.
Thank you very much. It's a pleasure and honor to introduce today's speaker, Professor Neil Shear. Professor Shear is a professor of medicine, dermatology, pharmacology, toxicology, and pediatrics. He is currently the head of dermatology at Sunnybrook Health Sciences Center and the director of Drug Safety Research Group at the University of Toronto. He earned his BSc degree in chemical engineering and then went on to study medicine. He then specialized in internal medicine and after that in dermatology. He also took fellowships in immunology and clinical pharmacology, and he has been the director of clinical pharmacology at Toronto University for several years. Professor Shear has been a president of several organizations, including the Canadian Dermatological Association, the Canadian Professors of Dermatology, and the Canadian Society of Clinical Pharmacology, among others. Professor Shear is a world leader in skin pharmacology, drug safety, and in dermatology and in cutaneous adverse drug reactions. He has written more than 400 papers and over 60 book chapters, many of which deal with this issue. He is a recipient of numerous awards and frequently invited speaker all over the world. With the constant addition of drugs and biologic agents into medicine, adverse cutaneous drug reactions is an ever-increasing clinical problem, and some of these reactions, unfortunately, may kill patients. There is no one suitable more to review these adverse reactions and their current management than Professor Neil Shear. Please.
Thank you very much. That truly was a very kind introduction. It's a great honor to be here, and I'll just get going. So just about potential conflicts and warnings. Usually when you're talking about drug reactions, you're not exactly helping to sell drugs. So I don't have any relevant conflicts. I do want to mention there's this book that Jerry Litt started many years ago. It's the 24th edition now, and I'm going to be the editor for that. And I finally got the publisher to make an app for it. So if you're interested in drug reactions and interactions, actually it is an amazing resource, but that is a conflict because I do get royalties from that. So one of the things I want to talk about is TENS, which is toxic epidermal necrolysis spectrum. I think over the years we've learned so much more about these severe drug reactions that we can't get rid of the old names, but we can at least start to adapt them to what they really mean. I'm also going to talk about the gliptin group of drugs for diabetes, the PPD4 inhibitors causing bullous pemphigoid. Is that better? Okay. Okay, is this better? Oh, okay. Oh, there, now I feel alive. All right, TENS is toxic epidermal necrolysis spectrum, and we're going to talk about that. I'm going to talk about gliptins, the PPD4 inhibitors for about causing bullous pemphigoid, and severe drug reactions, basically recognizing what these are clinically. A photograph can look the same for something that's mild and something that's life-threatening. But the patient, when you see the patient, they're very different. One is very sick and one isn't. But just looking at the rash doesn't help. And I especially mention that because people want dermatologists, oh, look, I have this picture on my phone. You know, what do you think? And we have to be careful with that. So over the years, when I started collecting data on this and going through paper charts at the Hospital for Sick Children, surrounded by all these huge charts, you learn a lot when you see the notes that people write and what their attitudes are. And it's a different thing. Drug reactions are different than most other diseases because people don't approach it as if they would approach a disease. If you see a patient who has very low blood pressure in the emergency department, you think, oh, they're in shock. When you get to a drug reaction, people, oh, what drug caused it? They want to make a guess and make a game out of it. But for me, after 35 years in it, it's not a game. It's fun, but not a game. So this is just a simple classification with looking at two of the three pieces of the puzzle. One piece is, what does the rash look like? The second piece is, the person sick or not? And the third piece is the pathology, but that's a whole other talk, and I'm not going to get into the pathology as much, but it's also a critical part of what I see as a triangle of 3 points. And so, for example, you have an exanthem, which means it looks like it's a viral induced or infection-induced rash, but exanthem really means is something from the inside is causing this rash on the outside. If it's in your mouth, it's an enanthem. And so the exanthem is the typical, oh, that looks like a drug rash thing. However, if that person has a fever and is otherwise ill, then that's stress. So I'm going to get into those main ones in the bottom, the ones that are more complex. And I break them down into these two groups, simple and complex. And there actually is a system. I just made that up, but there's actually a system by someone called Stacy who looks at processes. And in these processes, depending on the information you have and the information you wish you had, you can decide whether something is simple or complex. But between the two, he has complicated, and at the far end of really being in trouble, it's chaos. But just simple and complex, those are the two main groups. So let's just talk for just a brief second. My whole career started looking at what is now called dress. And what we saw was the person I went to work with, actually, his name is Steven Spielberg, an easy name to remember. And Spielberg was coming from Johns Hopkins to Toronto to be on staff at the Children's Hospital. And he had published a paper in the New England Journal on phenytoin-induced liver toxicity and in vitro studies to look at the mechanisms of this condition. And when I went to join him, he could come just before I started. And I said, you know, I like your paper because these people had rashes, and it's a systemic disease. And he said, that's a good point. Let's really look into that. And we published that a long time ago. So dress. When people use this term now, you'll see they're all capitalized. I like to make the E in the middle small because it doesn't have to be there. People do get eosinophilia with dress, but they also get atypical lymphocytosis early, and then somebody would say, oh, well, it's not dress, but it is. They say, oh, it's a mononucleosis-like syndrome. Yeah, it is, but it's dress. And when the rash gets better, the people will shoo the dermatologist away saying, yes, but now we have to deal with the hepatitis, the hypothyroidism, and other things. That's all part of that disease. It's a complex constellation of inflammation in almost every organ, except there is no arthritis. But anything else you can think of, you'll see with dress. You can see central nervous system involvement, you can see renal involvement, whatever, and huge lymphadenopathy sometimes, so it's often mistaken for lymphoma. And they have this exanthem. If I showed you this picture and said, what do you think this is? You could say, I don't know, it looks like a drug rash. Yeah, but is it a simple exanthem with no fever or anything? No, they've got a fever, they have lymphadenopathy, they have pharyngitis, they have a swollen face. All those things are part of dress. This patient's happened to be from verapamil, but you can see it from anti-epileptic drugs. You can see it from sulfamethoxazole. There's a whole group of drugs that can cause this, but the usual ones are going to be drugs like carbamazepine, or again, sulfamethoxazole in cotrimoxazole, as well as with other drugs, there's no doubt. So that was dress. Now, serum sickness-like reaction. The names we have in our drug reactions are actually quite sad because we don't have great names. Serum sickness-like reaction almost sounds like it's telling you something, except it's telling you something that it isn't. It isn't like serum sickness. It is not an immune complex-mediated disease, and it's quite different. And this is a picture I got off the internet last night, and the reason it attracted me was because there was a warning that you should give credit for this. So I'll give credit. It's Elsevier's picture, except it's my patient. And oddly, the story was not there, but it was funny to look at this screen of pictures and go, wait a minute, I know that picture. Now, I didn't take the picture. These were in the days when people didn't take pictures. And I said to the mother when I saw this boy in recovery, I said, do you happen to have a picture when he had the rash? Yes, she did. And so she gave me a copy of the picture. What you can see, because you can see the sheets are nicer than we would have in the hospital, he has this urticarial eruption. It's raised at the edges, and if you look at his back, you'll see these streaks. That's dermographism, where he's been scratching. And this is from cefaclor. Cefaclor, it's not used as much anymore, but it was a big a big deal in an antibiotic for children because it actually tasted good and seemed to be very safe, but had maybe a 1 in 200, depending on the study, incidence of this condition, serum sickness-like reaction. You can also get it from other drugs, and some biologics can cause it. You get this urticarial rash, but they have arthralgias and arthritis. This kid can't get out of bed. His knees are all swollen, his fever. And after the rash goes away, the dermographism could last about a half year. And I always tell dermatologists, if you see a child coming with dermographism, you should ask if they had a drug reaction before. The complement is normal. There's no renal involvement. They don't have immune complexes. It is not like serum sickness, which one gets from, say, again, proteins, things like that. So going back to this classification, this one's called AGEP. Another, not a bad name, acute generalized exanthematous pustulosis, which actually says quite a bit. Now, in AGEP, you can see these clusters of pustules, and clinically, it looks like pustular psoriasis. Clinically, it smells like pustular psoriasis. The smell of the neutrophils, whatever it is very distinctive. And they have a fever, like generalized pustular psoriasis. And what happens with this one is you walk in the room and you're told a story, whatever story we're told. People show you a picture, they tell you a story, and you say, oh, thank you very much. Then you go see the patient. And you walk in the room, you can smell it right away. And for me, the first thing I think of is pustular psoriasis. And then I try and think, oh, if I thought of pustular psoriasis, I better think of AGEP. And this just came out, I guess in the 1980s from France. And suddenly I realized all these people that I saw when I was a resident who had pustular psoriasis, many of them did not have pustular psoriasis. They had this reaction. And it was like, oh, like a light went on. And they're sick, they don't feel well, they're usually admitted to hospital. Of course, with many of these conditions, if you have a rash and fever, then everybody has to rule out sepsis. And you come in, you say, they're not septic, they have no criteria, and all the latest criteria are out now, no criteria for sepsis. Well, you can't do anything, you have to wait for 3 days. And then we treat them and make them better. But they're simple drugs, beta-lactams in children and in adults, calcium channel blockers. But again, you take a look at a book like Lit, and you'll see there's lots and lots of drugs that can induce this. One interesting thing about this condition, if you hear the story and the person was on 3 or 4 drugs, and they say, well, we don't know, we might need to use some of these drugs in the future, you can actually patch test where you put all these different drugs on their back with these little aluminum discs. We put them on like we test skin allergy. And the beauty of it is, if they do react to some of it, it'll come up with little pustules. It'll just reproduce the condition, and you know that drug was the one that caused it, so that's nice. Okay, so let's get back to TENS. That's this one here. Now, I used to not like the name TENS. We used to call it the TEN, but now I find it's easier to communicate this as a spectrum of disease. And this is toxic epidermal necrolysis, or TEN, and you can see this person has blistering all over. It has a mortality rate of at least 20%, even with good therapy. And I'll get into the therapy because I think it's an interesting evolution for a rare disease. New drugs that come out. There was one drug, sorbinol, that came out, which was an aldose reductase inhibitor and totally reversed diabetic neuropathy, retinopathy, and nephropathy. But there was an incidence of this. Structurally, it was very similar to phenytoin, and we did publish a paper on that, but they thought other drugs could do that. But sadly, that drug is dead, sorbinol, and it was an amazing thing. People would come in and say, I would take that drug again. My pain went away within days, but nothing's come to replace it, which is a tragedy. Nevertheless, because you'd like to be able to genetically screen people and say you can take this or not. It should be, if anybody's ambitious, that's a drug to get back. And Pfizer had developed it. So toxic epidermal necrolysis. Now, this is the question I always get. Somebody who's read an immunology textbook says, is that a type 4 reaction? Now, I don't know why people ask that, but they do. Yeah, to me, type 1, 2, 3, 4. And I've heard Robin Coombs talk. I didn't think he was that smart. But he certainly wasn't a good speaker. But okay, so I put this up. This is from an article that Elizabeth Phillips and her group did from Vanderbilt, and it summarizes a lot of material that Werner Pichler really developed, and he's in Switzerland, but it had been in NIH. And what happens is with the type 1 IgE that people know, type 2, which is like immune complex or matrix forming, and type 3. But then when you get into type 4, there's a whole bunch of subtypes, because we know now where you have, T17 cells and T1 and T22 and all these different cells, you actually get different types of reactions. And they lead to different clinical consequences. So you've got a drug, and then the drug goes into a person, and there's all this different metabolism and interactions with the immune system, and then that interaction is expressed in different languages in terms of different types of rashes. So the clinical presentation of TENS, this severe reaction, it can look like varicella, like chicken pox. And especially in dark skin, it's hard to see. You might have people who probably were not immunized, and you think, oh, they're very sick, they've got systemic varicella, and we're just waiting to hear, but didn't show any virus, but we think that's what it is. And I mention this because I've seen several legal cases, and people even have come up at meetings and said, you should mention varicella, because I saw a patient with that, and it wasn't, it was this TENS. It can just look like a simple exanthem, and really you'd have to look with a side light and be very careful, but you can see that there's blistering. There might be that Nikolsky sign where you can push the skin and it comes off. We described several cases years ago of acute lupus. I saw one recently, a young lady with lupus, and came in with blistering skin all over, not the lips and the eyes that we see with TEN, but she looked very well, actually, considering how bad her skin was. And the pathologist was hounding me on the phone to warn me that she had TEN. That's what he saw in the pathology. But it was just from her lupus, and she responded to that therapy. Other differential diagnoses are listed here. You don't have to know all those. But of course, we see the graft versus host disease. And in some of these, just because they're not regular TEN doesn't mean they're not very scary and dangerous. I had a phone call recently from an intensivist at a hospital across Lake Ontario from us. And she started to tell me the story, and I said, wait, stop. Are the lips involved? Are the eye involved? No. But they have a fever and their skin sheeting off. Are they renal insufficiency? Yes. And do they have staph septicemia? How did you know? And I said, that's staph scalded skin, which we're used to seeing in children, but adults can get it in the right situation and end up usually in an intensive care unit, and everybody's running around. But really it's just a staph toxin that's causing it. And so many years ago, in the 1990s, with the European Union emerging from the European community, there were funds for clinical trials or other investigative approaches to get groups together to look at things where you had many countries working together. And Jean-Claude Rougeau, who's the lead author here, was really the driving force behind creating studies that included the groups. And Luigi Naldi from Italy, and Bertolt Czarny from Germany, and then the French group. And I was called in because of work we had published and some stuff we had helped Rougeau with. But it was a very interesting experience. And we made up a classification system for doing this huge case control study. It was published in the New England Journal in 1995. And we tried to verify this. And we came up with a new definition of what these are. I only mention this because it's been interesting over the years. This was done for a clinical trial. But whenever you do this, it becomes like a rule for people to follow. And they say, well, I don't know. Are they overlap? Are they SJS? And it doesn't matter. It's part of a spectrum. And to show you that pictorially, because that's the way we in dermatology like to think, erythema multiforme is a term. Erythema, you think of red, multiforme, could look like anything. And so anybody who sees a rash says, oh, it could be erythema multiforme. And that's nonsense, actually. It's a very specific condition. The other thing that's confusing is with the lymphocytic infiltrate you get, a pathologist could say it's consistent with erythema multiforme. Consistent with means it's not that, but it could be that if you have an imagination. It's a funny term and for me to read and to see even early drugs in development, they get a rash and people don't read the description of what the pathologist saw. They just look at the bottom line, consistent with drug. But that could be just one eosinophil that is seen. Anyways, erythema multiforme has this 3-ring target. It's usually acral. So in the distal extremities, patients aren't necessarily sick. And if you can find a cause, it's usually post-viral. You have other TEN-like things where they're just sheets coming off. And then you've got other things called erythema multiforme major. This young kid was not sick, but he had these target lesions all over his body, mostly centrally rather than peripherally, with these lips that looked like he'd burned it on hot soup, but he didn't. And then you've got this SJS to TEN spectrum, which is I would call TENS, the toxic epidermal necrolysis spectrum. So there's erythema multiforme, but this is SJS to TN TENS. These are sick people, and these are people who will there's two choices really when you have this. You suffer and then you die, or you suffer and you survive, and then you suffer the rest of your life because you're afraid of not only drugs, but doctors, because a doctor might prescribe a drug. And I will tell you, I started seeing all these patients. We have the only true burn unit in our province in Ontario. And when we see these people, they're in a coma, they're treated very specifically, and if they survive, I see them afterward to go over everything with them and their family. They come, we spend an hour, 2 hours together, and I tell them, are you afraid of this? Is that what you're thinking? And people, they start to cry. It's quite an emotional thing for them to hear that they don't have to be fearful of everything the rest of their life. Because you can look up any drug and it'll say TEN on it, and they think, oh my God, that drug causes it too. But that's not the same. It's like you could look up a key for a lock. That key doesn't work in every lock. It only works in one. And it's an interesting thing to see, and it's very rewarding. Okay, so they're SJS, Stevens-Johnson syndrome. This is the use of Stevens-Johnson syndrome is the way that I found emergency physicians get us to go to the emergency department. I think we have a patient with Stevens-Johnson syndrome, or I think I have a patient with toxic epidermal necrolysis. So just before I send a resident down to the emergency department or have the patient come up, I have one question. And my defining question is, how did the patient get to the emergency department? And if they took the bus, then they don't have Stevens-Johnson TN. And I've seen that before. There are forms of things that look like that. They took the bus. I said, okay, then we'll get down there when we can. So here's a boy with erythema multiforme major, and here's that patient with TENS. But if it's at the early end, which is not a healthy end, they're very sick, but they have those lips that are all crusted and bleeding, and their eyes are red and sore, we use the term Stevens-Johnson syndrome. Now, Stevens and Johnson were pediatricians who in 1922, in one of the pediatric journals, had a picture of two young patients, teenagers, who had these spots on their body. They were not, erythema multiforme was described in the 1800s, but this was different because they had these really red eyes and mouth. This was before any of the drugs we have except aspirin. These were not drug-induced. These were infection-driven. And so the term Stevens-Johnson, and for toxic epidermal necrolysis, in many countries in the world, it's called Lyell's syndrome, and Alan Lyell described that. He's a Scottish dermatologist, and he described that in the 1950s. And if you look back at any disease, like in dermatology especially, there's usually line drawings or something, and you look back at his papers and you see what we now know is probably linear IgA bullous dermatosis, what his staffs called it skin syndrome. It was a mishmash of things. It was not what we call TN today. So what about Stevens-Johnson? It's a term that's bandied about, and we sort of tried to get rid of it, but I've given up. I've tried to refine it. So this is my mishigas. So I would look at this and say there's two types of Stevens-Johnson syndrome. There's the one that really is what Stevens and Johnson described. They have a mucositis. It might be hemorrhagic. It doesn't have to be like it is in TN. They may have a classic 3-ring target, but it may be in an atypical place. And it could be drug-induced. That's possible. In one of the studies that came out of the big study in Europe in the 1990s, Ariane Okiye was the first author, was in what was then the Archives of Dermatology. About maybe 15% of people might actually have that being drug-induced. But it could be from infections. And there's several terms now floating around for mycoplasma-induced rash and mucositis, which they call MERM. But when you see it, it's like Stevens-Johnson, but they're not sick like that guy who's lying in the bed in the picture I showed you. They're not that sick. They're sick, and it looks bad. And the other thing that I've learned also over the years. Whenever we had anybody with a mild rash even, you'd always be warned it could turn into toxic epidermal necrolysis. No, it could not. It is not toxic epidermal necrolysis, so it will not turn into toxic epidermal necrolysis. It's not a magic trick. And with this too, these kids who have this mildish form of a bad disease and have just a mucositis like this MERM, they can be sick, but it's not going to turn into toxic epidermal necrolysis because it isn't that. And that's very helpful to know. And even from a treating point of view, I've done these just over the phone, and you can see, you can diagnose it, these flaming red eyes. I'll get to that. And then you've got this milder version. So mycoplasma and Stevens-Johnson syndrome, this is the kind of picture you'd get. The mouth inside is terrible. It's all blistering, and the eyes are all red. And the doctor sends me this photograph, and I say, and they think it's from, say, amoxicillin or another antibiotic. But why were they on amoxicillin? I said, well, did they have a cough? Yeah, they did. They had a cough. So they have mycoplasma. And you can treat them simultaneously. Their mouth is horrible. They can hardly talk. They can't swallow. They're drooling, and they're suffering horribly. And we've tried IVIG, all kinds of things. We give them cyclosporin for the inflammatory part. Just liquid cyclosporin goes in. It's easy to take. And they're better in 2-3 days. And we treat at the same time. We'll treat the mycoplasma, say, with a macrolide antibiotic. And within 3 days, they're like better people. You see them, and they're, otherwise it goes on, could last a month or more. And I was surprised, Dr. Levy, who was a infectious disease fellow who was working in our clinical pharmacology lab, really wanted to review the charts in the hospital, which is a punishment with the paper charts, I'll tell you. And so we reported these 8 cases back in 1991. And for many years, people were calling me, you're the expert in this. I said, I'm not the expert. He said, no, but you have the only paper on it. But now it's becoming a thing. So there's 2 papers, one from the Journal of the American Academy and one from an allergy journal, Allergology International, just looking at the distinctive morphology and disease outcomes of the mycoplasma-induced rash and mucositis and how it distinguishes from Stevens-Johnson. Well, I say, let's not distinguish it from Stevens-Johnson. Let's say Stevens-Johnson type 1, and then we don't have to worry about, what we call it. But we just know that we have these clues. And then the Japanese group looked at all kinds of different things about which ones were drug-induced, which is more Stevens-Johnson type 2. And as I mentioned, there's many different ways to treat the milder SJS, the type 2. But I think the cyclosporin, and if the eyes are involved, ocular care is very important because if they've got that severe form, then you can get blindness. And we had an NIH, we got an NIH meeting grant a few years ago, and I had actually quite a large meeting in the U.S. And James Chodos, who's at Harvard, presented the ocular things. The one thing that was new to me was about getting these sort of thick, scaly things at the edge of the lids, and that's not a good sign. And people do go blind, and we do treat it with amniotic membrane, which works very well. And his saying, and this is his quote, if you see something, do something, and I appreciate that because it's not the kind of thing, well, we'll see what it's like tomorrow. Oh, they're blind. No, you can't do that. You have to treat it. If you look at the really severe end, that should be treated in a unit that's experienced with it, but it's a rare disease, so it's hard to necessarily find that. For the ocular care, these amnion implants are fantastic. Vaginal care is important, even in children, because they don't get examined carefully every day. You're not going to have somebody go in to an 8-year-old girl and examine her genitals every day, and then you miss something because often they're in a coma. They're not going to complain about the pain when they're peeing. They've been catheterized. And so generally what I do is I just tell, we try to get ophthalmology involved, and they just come down and say, oh, they're fine. And that's not good enough. They have to come every day. So I just have every day, they use a tampon, and they cover it with a very strong steroid clobetasol ointment. And you put that in every day. It'll prevent the disease coming and at least make sure somebody looks every day. Now, which drugs do we treat it? IVIG had a wonderfully sexy story about fast ligand, which was great, but it didn't really turn into necessarily a great therapy. Intravenous steroids can be highly impactful, and I remember treating cases when I was a fellow even in the 1980s. We give huge doses of solumedrol, and people with terrible disease would get better right away. But they have their issues. Cyclosporin has emerged as a sort of a star in this area, and etanercept and anti-TNF therapy became attractive because of the role of TNF as well as tumor necrosis factor, as well as the idea that it was driving the disease, and then you could block it with a TNF and reduce granulysin. So I was about to give a talk on this, and I was meeting one of the residents in a program, and he said, is there any evidence, though, really, that etanercept works? I said, well, you know, there's a lot of anecdotal stuff, but not good evidence. Except that night there was. And so I thought, well, I better show that. And this is in the Journal of Clinical Investigation, a very good high-impact journal on a randomized controlled trial of TNF-alpha antagonists, in this case, etanercept and Brel. And it was both a clinical story, but there's a basic science story to go with it as well. And Wen-Hung Chung in Taiwan and the group have been doing this wonderfully for probably more than a decade now. And there's one picture I have here is about oral mucosal healing. And for example, on the right, you've got a body surface area of greater than 10%, which means there's a very high mortality rate. And the red line is the group that's got the etanercept, and the darker green line is the corticosteroid group. And what you see here is that you start to get oral mucosal healing within 4 days if they're getting etanercept, and if they're getting a steroid, it could take 14 days. And that's not a very pleasant extra 10 days. And there's other outcomes, but it's just one of the many measures they used. It's a 12-page article that has a whole bunch of supplementary material. If you're really interested in this condition, it's the one to read, but it's quite a bit. But there's only one more slide that I want to show from that publication, and it's about the granulysin and the TNF-alpha release. This is ex vivo. They're cells taken from the blisters, and they're cultured, and they look at what the cells are doing. And then they're putting in the therapies to see if they prevent granulysin and TNF-alpha from being coming out into the fluid from these cells. So on the left, you're looking at granulysin, which will be probably the major driver of the necrosis. So it's toxic epidermal necrolysis. That necrolysis is driven by granulysin and TNF. And so what you see here is if you've got etanercept, and at the other end of that figure, on figure A, you have a corticosteroid, both of those reduce the granulysin, which is good. So etanercept is good, corticosteroid is good. I showed you a picture that corticosteroids don't work as fast for mucosal healing, but for some others, they work just as fast or even faster. So here, okay, they both do it. Well, what about intravenous immune globulin? Not so good. And what about cyclosporin? Not that much different from control. So etanercept and corticosteroid in this model look very attractive. What about TNF? Exactly the same story. Etanercept and corticosteroid look attractive. So you've got a choice. Now, how's the etanercept given? We give 50 milligrams, and we give it maybe every 3 days until we start to see healing, and then we can back off. And it doesn't end up being, it's much more inexpensive than IVIG, which costs a fortune and is not renewable. It's from a human source. So, okay, so we think we know what we're doing. But here's the summary of what they saw in the clinical study. The etanercept decreased the predicted mortality rate. So for toxic epidermal necrolysis at that bad end of that 10 spectrum, we've got reasonably good system called score 10, which can predict the likelihood of live, die. And the predicted for these bad cases was about 20%, and the observed was less than 10%. So you really had an impact by using the etanercept. Okay, the corticosteroids could do that too. If you looked at reduced healing time, again, the etanercept won overall on the skin by just a bit. But the big issue to me was that the etanercept had a lower incidence of gastrointestinal hemorrhaging. 3% compared to almost 20% in the corticosteroid group. You've got a very stressful situation on a patient. You're going to expect you might get some gastrointestinal bleeding, and it's a big deal. On top of everything else, for them to get that is a big deal. So there's a lot to be said for what the role of etanercept might be. We've been using it now for probably about 12 years, and it's become part of our practice. I just want to go quickly into a case that we saw that I think highlights a few of these issues. This is a lady from India. She's about 40 years old, and she presents to our emergency department truly with Stevens-Johnson syndrome. She is sick. This could be a type 1. It could be infection-induced, it's hard to say, but it could be the beginning of toxic epidermal necrolysis, and she had skin lesions on her body that did that. But you can see the mucositis on her lip there is all hemorrhagic and crusting, and she's got a nasogastric tube because she can't swallow and she can't talk, and she's in a lot of pain. So that's the kind of picture that you see with a type 2 Stevens-Johnson. And she had taken carbamazepine, which she'd been given in a walk-in clinic because she had headaches that wouldn't go away, which is not an indication for carbamazepine, but the doctor said, no, try this. This should be good. It was not. And she came to our emergency, and then we admitted her to the hospital, and she was in the hospital for about 4 weeks. FDA, Canada, other groups have a thing that says patients with ancestry in genetically at-risk populations should be screened for the presence of HLA-B star 1502. So HLA, the human leukocyte antigen, it's important here because when you get this foreign chemical in the body, carbamazepine, it actually fits right into a pocket on the HLA-B star 1502. And if you go to 1501 or 1503, it doesn't fit, bounces around. And you can model this on a computer, so-called in silico modeling, and you can see how it fits. So studies have been done that show that not only is this very tightly associated with this drug-induced disease, but also that it's people who are from South Asia. This Indian woman fits that area where there's a higher incidence of this, higher prevalence of this specific HLA. And you know that if you screen, and this has been shown in Singapore, the Taiwanese did a huge study, if you screen, you'll take that 7-8% of the population and not give them this drug, you don't see toxic epidermal necrolysis, which is a horrible disease. Now, what's more common and what most people will see in a gene that's more widely distributed, perhaps, is allopurinol-induced toxicities. But that's another story. So these are basically people of South Asian ancestry, so not Japanese, not Koreans, not Mongolian, not northern China, but all the way from Pakistan over and down into Philippines and anywhere else in the world they are. So these are some of the genes that we can test for. The full table is huge now. It's a big page of drug screening, and we've been involved in a lot of these studies. The 5801 for allopurinol, labs will do that and can let you know if the person is of South Asian ancestry, or even if one parent is. Then you can get into trouble. And I just saw, actually, in terms of meeting people after it, a Chinese woman who's married to a Caucasian man, and the daughter was in, very delightful lady, and I said, I know you're wondering, you know, if you have a risk, so we'll test your mother for the gene, and I'm waiting for the results, but, you know, she wants to know whether she has that risk, and would her children as well. The 1502 carbamazepine as well, and abacavir, a drug used for treating HIV many years ago. We started doing patch testing before we had a gene. You see they get a huge blistering reaction on the patch, and they can develop, the reason it's important, DRESS is a bad disease, but in this condition, if they get re-exposed, they get better. They stop the drug, they're better in 2 days, the abacavir patients, and you figure, well, it couldn't be the drug. And you give it to them again, and they go into shock, and people died. So it's a very specific type of reaction that's quite aggressive on re-exposure. This is a map from the group that we put together in clinical pharmacology and therapeutics in March. And it just shows the black little parts of the bar show you the prevalence of the one for carbamazepine, the HLA-B star 1502. And so the lady that I saw, that Indian lady, is in that sort of area. Obviously, India is to the left or west of that, but that whole area is what's involved. And if you look at here, this is US Asian ancestry. So in Toronto, we have a very large Asian population. And so we do see these patients. And we just did a survey. I don't have the final results, but we sent a survey around to the academic physicians at all the university hospitals. And it was actually an educational survey. So you would be asked a question, are you aware that there's this HLA-B star 1502 genetic testing for carbamazepine? Yes, no. And then, you know, do you know there's one available? Yes, there is. And it would just go from step to step. And we got a lot of interesting and quick feedback on it, but people said, I did not know this. I don't know why I didn't know this. Why aren't people telling us? Well, we tried, but now they're really interested. Anyways, the other one on the bottom, you can see right on the bottom is the Singapore Malay ancestry. So in Singapore, 3/4 of the population is Chinese in origin, and 12.5% are Malay. 1 in 5 Malay people have this gene. And so they actually have mandatory screening before anybody gets carbamazepine, and their rates of TN just dropped for that. So she did have a positive diagnosis, which was helpful in confirming that it was indeed the carbamazepine that she'd been on for 3 weeks before, and not the amoxicillin she got for her sore throat. And her throat was sore because she had Stevens-Johnson type 2. And these are references, and I put them up because Ronnie Dodiagad was the first author on these, but they were really good work, especially on the survivors and the emotional complications. We get this question, well, what do you do? I said, well, it's not what I do. Each patient is different. There are unique circumstances, and each plastic surgeon I'm working with who's a burn doc, they have their own attitudes, which can sometimes defy rationality, but they will do what they want to do, and we try and work it out. But I thought we should publish that, and a group from Vancouver has published stuff in the Burn Journal recently as well. But it's just our guidelines. So I'm going to also finish up with something called the drug reaction of the year. Now, there is no such thing as the drug reaction of the year, but there will be. And the North American Contact Dermatitis Group has something called the Contact Allergen of the Year. And they're trying to make contact allergy very sexy. And they go around and talking about this allergen of the year. And I thought, well, we should have a drug reaction of the year. And for me, and I chose this one, and I agreed with myself, I thought it was a good decision. I see an old man with bullous pemphigoid. So for those of you who aren't dermatologists, this is an autoimmune disease with IgG in the skin, but it comes on as immunosenescence comes up. You start to get this. So clearly the brakes are coming off somewhere. Because usually you expect if you're going to get an autoimmune disease, who gets lupus at the age of 90? I mean, if it isn't drug-induced, you just don't think. But things, as you start to get immune senescence, this bullous pemphigoid comes up. So an old man, an 82-year-old man comes in with bullous pemphigoid, it's you don't think about anything. And what about drug-induced? That's what this talk is about. Well, Sarah Brenner in Israel has published so many long lists. And in the lit book, I looked it up, there's 54 drugs that have been reported to cause bullous pemphigoid, and yet we don't really see that in clinical practice. When we see bullous pemphigoid, we don't think, oh, what drug are they on? But we should, and especially the gliptins. So this patient was on sitagliptin and lisinopril, and here's a list of some of the gliptins. Some of them are combined with metformin and with other drugs like pioglitazone to work in diabetes. There was a recent paper out, I think it was in a New England Journal, looking at all these various new classes of drugs for diabetes, and actually gliptins were associated with a higher mortality overall, and whether that's real or not, they certainly were not a group of star drugs. So it makes me feel better. If I think a gliptin caused bullous pemphigoid, then I can talk to the endocrinologist, internist, whoever's looking after the patient, and say, maybe you can do better because the gliptin's causing a problem. So here's a paper from 2013 in JAMA Dermatology, and the green line is the bottom of the epidermis, and that's where the antigen is, and this is a labeled antibody against that antigen. You can see it lighting up, and that's classic for bullous pemphigoid, and this is what my patient looked like. So this was another lady I saw shortly after that patient, and this lady, a 75-year-old woman who has ended up having the pathology, but clinically was classic bullous pemphigoid. You've got these urticarial plaques with these big tense blisters, and she'd been on linagliptin for 2 years. You think, well, you've been on it a long time. It couldn't be that. I always tell patients, whether it's patch testing or whatever, I don't like statements that start with "it couldn't be that because." They're usually wrong, and because we don't know enough to always say that. And in fact, that's not atypical. And when you stop the gliptin, the bullous pemphigoid goes away in a couple of weeks. They may have had it for years, but it goes away in a couple of weeks. Why they get it, I don't think we really know. There's hypotheses, but we don't know. And I have to give her oral steroids. When I see a patient with bullous pemphigoid, almost all of us will do this. We know that with some prednisolone, they're going to get better very quickly. And as soon as you go to write it, you go, oh, wait, you're diabetic. Oh, okay, now if I give you the now this lady was bipolar, And I was afraid that she was going to get hypomanic and everything, and risk of mania, hyperglycemia because she's diabetic. And then you go, wait a sec, that's the aha moment. You look for the gliptin. So the average age in one study in the British Journal in 2016 was 74 years old. 10 months of exposure was the mean. She was on her drug for 2 years, and switching to another gliptin has a risk of recurrence. There's more to gliptins than that. There's angioedema, and this patient that I had, that man did not have angioedema, but he was also on an ACE inhibitor and a gliptin, and combined, they block the breakdown of bradykinin as well as substance P and have a higher risk of angioedema. The other drugs that cause bullous pemphigoid, so drug-induced bullous pemphigoid is the, if you will, the drug rash of the year. Immune checkpoint blockade immunotherapy for all these different types of cancers causes this. Now, New England Journal had this lovely review on this, which was then followed by every specialty saying, you didn't mention this, you didn't mention that. So what did they have for dermatology? They had vitiligo and rash, which is really understating what we see. We see all kinds of immune diseases, including immune hair loss and terrible rashes. But we're seeing that with these immunotherapies. So this is more about bullous pemphigoid and checkpoint. How big is that concern? Is it a scream? Is it a yawn? I think for the bullous pemphigoid, it's not that isn't going to kill the person. It makes their life miserable because it's very itchy, very itchy. People do not like itch. And they're going to be on steroids for a long time. So if you can stop the drug, and who knows what else it's doing, you're only too happy to do it. So the aha moment is, if I see a patient with bullous pemphigoid and I'm going back through my charts, people are coming in, and I say, wait a minute though, how long has this person been, and have we been following them, and are they on a gliptin? And we've had a few patients that we stopped. So for dermatologists, you'll see these people. So I'll just summarize by saying TENS is a term we're using now, toxic epidermal necrolysis spectrum. And at the milder end, I'd call it SJS2. The full end is TEN, and these people still can get sick and die, but we're getting better and better at doing studies in a rare disease. Gliptins cause bullous pemphigoid. End of that story. They also can cause angioedema, and that systemic signs with a rash will tell you it's a systemic disease, and you have to think of basically every organ in the body. Toda rabba.